I would also like to congratulate you on this special day. This is a day specific for all men of medicine. As a psychologist and psychiatrist, we have different preferences and we use different terminology. And on this occasion, I would like to express my condolences for the decease of Professor Esad. I'm very glad that the previous speaker touched upon major concepts. It makes things easier for us, for me. Today I will be talking about meta-analysis study of Kirsch, the wrong messages from the study, different points of view. We make professional deformation, evidence-based medicine, and reading meta-analysis. Technically, criticism for meta-analysis, general criticisms, and then I will talk about different approaches in psychiatry and measurement principles. You know that this study was published last year in March. It is from a very well-known university. You know that Kirsch is a psychologist, and he has studied the nature of the placebo effect. What I'm going to say at the end of my presentation, I can tell you now, this meta-analysis does not come up with anything new. It's not a new concept, but Kirsch puts everything in a perspective. Within his own scientific studies, this specific study is referring to the importance and nature of the placebo effect. Placebo effect is also very prominent in psychiatry, especially in an antidepressant therapy. At the end of the study, he has come up with some antidepressants, and these antidepressants are quite efficacious. That is also not a new finding. We know that antidepressants are more effective than placebo, and they are superior to placebo, especially at the beginning of depression, and it's closely related to the severity of the depression. The editor and the person who prepared the paper, the writer of the paper, came up with different results, and therefore the media decided to read this differently, and they printed that antidepressants are as effective as placebo, or maybe even less effective than placebo, and the whole thing was totally misunderstood. We're not discussing the technique or the power of a meta-analysis. What is confusing here is that the objective of the study was not very clearly stated. You know that this whole thing was printed in the media. There was a lot of hue and cry about it. The public opinion got the wrong message, and they began to think that antidepressants are ineffective. They believe that antidepressants are totally useless, and our patients came and told us they don't want any antidepressants. Therefore, the Turkish Psychiatry Association decided to examine the subject carefully. I worked with Dr. Mesud, and we wrote an article in the Journal of Clinical Psychiatry. This is not the first time that Kirsch is creating a confusion. In 2005, he wrote a paper against antidepressants. You know that the sensational dimension has been taken up by the media. It is indeed quite provocative. The results of the study and the interpretation of the study should be totally separated. The study results are quite good. You know that there is an anecdote about a man from the Black Sea catches a flea, and and he tears off one leg, and of course the flea jumps. The second leg is torn off, and the flea is still jumping, and all the four legs are torn off. The flea cannot jump anymore, and then the man from the Black Sea says, when you remove all four legs, the flea cannot hear you, because he cannot jump, he cannot hear your command. In my opinion, that is not the way to approach the whole subject. He may be a psychologist, maybe he has close relations with a pharmaceutical company, but that is something that's totally beyond our discussion today. Evidence-based medicine is the basic principle in psychiatry as well. You know what evidence-based medicine is? There is a pyramid of all types of tests and studies, and the best is randomized controlled studies, and after that systematic assessment and evaluation and meta-analysis. A meta-analysis was performed, and as Kish said, the meta-analysis indicates that antidepressants are ineffective. That is evidence-based medicine. Actually, meta-analysis sometimes could be as ineffective or unacceptable as anything you may base on your experience. A meta-analysis should be expressing previous studies. It should lead to future studies as well, and the results should be reflected into daily clinical practice. Meta-analyses are very useful, but we must understand that the meta-analysis studies should be carried out on a specific subject, and they should be interpreted correctly. The title of the meta-analysis is the efficacy of antidepressants in depression disease, and the placebo effect in depression disease. That should have been the title. I think the title of the meta-analysis is not the right title. We could carry out a study, and they don't have to randomized control studies, and we could create a meta-analysis trying to understand the impact of placebo. This meta-analysis also has some weak points. We know that the meta-analysis has some weak points, and they have been taken into consideration. The publication bias is something we have to keep in mind. In this meta-analysis, Kirsch has also included unpublished articles. There are also certain journals who do not use a reviewer, and therefore they're not very reliable. And we know that sometimes meta-analysis by its nature can be quite difficult, because in psychology and psychiatry certain things are very hard to measure, and there are subjective evaluations. Let us look at the Kirsch study. It's standard meta-analysis. He is also paying attention to publishing bias. He applies to the FDA fluoxetine, venlafaxine, nefazodone, paroxetine, sertraline, and citalopram. He has access to data of 47 studies on all 6 of them, and sertraline and citalopram have been excluded, and 5 studies do not have final measurement assessments. Therefore, he removes these drugs, citalopram and sertraline, because there's the bias effect. So 35 studies, 5 about fluoxetine, 6 on venlafaxine, 8 on nefazodone, and 16 on paroxetine. These are the studies which are included in the meta-analysis. The characteristics of the studies in this meta-analysis, they are all randomized, double-blind, placebo-controlled studies. The treatment period is usually 6 weeks. I think a 6-week period of treatment will not be reflecting all the cases and will not lead us to come up with the correct result. And you know that many studies are not limited to 6 weeks or 8 weeks. There are many other studies where the effectiveness or efficacy of antidepressants are measured, and these studies are longer studies. At the beginning, there were 42 studies. 39 of them were outpatients. Only 2 were inpatients. 35 studies were taken into consideration, but we don't know whether they involve outpatients or inpatients. The primary outcome measurement is very important. How do you measure primary outcome? The objective should have been to measure the efficacy of placebo effect. Here he is trying to assess whether there is any response in depression or not. How do you define a response to treatment? 1 point fall in Hamilton scale or 3-point difference in relation to placebo could be one of the standards, and this is the NICE standard, and the author has selected the second one. The standard deviation is of course more than 0.5. There are 35 studies, 3,292 patients, active drug group. 1,841 patients have been randomized to the placebo group. In the active medication group, MD point is decreased by 9.60. Those who were randomized to placebo, MD score decreases 7.8, and the difference is 1.8. This is less than 3-point fall according to NICE. Therefore, the result seems to be that placebo is just as effective as antidepressants. A second analysis takes into consideration the treatment period. Average is 6 weeks. Actually, the treatment period is between 4 to 8 weeks. We don't know whether the treatment period is sufficiently long. Statistically, it has been examined. What about the different groups of antidepressants? Does that have any impact on the results of the study? You can see that all of them are less than 0.5, so for a different group of antidepressants do not have any impact on placebo response or antidepressant effect. We can say something about the severity of the disease at baseline. The initial Hamilton depression scores are between 23 to 30. One of the 35 studies, the average HAM-D score was 17. Later, he also mentions severity of the disease. In one of these studies, the HAM-D score on the average was 17. Kirsch himself says that there is a discrepancy between the number of data, the number of patients in this data. If the Hamilton depression mean is more than 28, then this study should be kept out of the meta-analysis. Mean standard deviation should be less than 0.5. In 3,292 patients who are actively treated, standard deviation is 1.24. In the placebo group it's 0.92, and this is less than 0.5. So according to Kirsch, all these studies come up with positive and acceptable results. He also says that the study included in the meta-analysis indicate that the placebo effect has a relationship with the severity of the disease. Our publication that we published in this Congress and in Clinical Psychotherapy, we believe that it is a good meta-analysis. It's taking into consideration publishing bias. There are other studies which have not been included in the meta-analysis. The new generation antidepressants, such as the new SSRIs, should have been included in this meta-analysis. And they should have been taken into consideration in the preparation of this meta-analysis. Antidepressant effect is greater than placebo, and as the severity of the disease increases, the antidepressant effect of the drug is also increasing. That is a finding which confirms previous results. But he has selected a more sensational title. I think that to say placebo effect is clearly related to the severity of the depression is a very controversial statement. The therapeutic effect should be the difference between the drug effect and the placebo response. Actually, this is the heart of the problem. There are also other things we have to take into consideration. Hamilton score more than 23 does not mean severe depression or very severe depression, because this is not a definition that has been accepted everywhere. The author keeps talking about most extremely depressed patients. We know that these are severe patients, but the definition is not very clear. And we don't know what he means by most extremely depressed patients. Actually, the group that he has selected is not very suitable, because most of these patients are outpatients. In his studies, he has taken volunteers, but they are volunteers without any suicidal risk. So when you refer to most severely depressed patients, usually these are patients who have suicidal ideation, and since you are excluding them naturally, the values are not always acceptable. Maybe they have been exaggerated, and that is another point where we can criticize the meta-analysis. He talks about the severity of the disease, but he does not define the concept of severity. A 3-point decrease according to NICE is not evidence-based. It's not part of guidelines, and it's not it's not an issue that we use on a daily basis. NICE has defined it as 3-point decrease, but it's not based on any clinical trials or on any evidence. It's an arbitrarily selected number. I think that the NICE standard should not be used for randomized controlled studies or trials. You have 2 minutes. Will you please end your presentation? There are many biases, errors. He also defines concepts such as spontaneous improvement. That is why we go for randomization or blinding in our trials. The previous speaker also said it very clearly. Placebo effect does not mean that there is no effect. Actually, therapeutic effect is the effect of the drug minus the placebo effect, and that is the difference. In the groups we see that there are 2 patients who are taking active medication and 1 patient who is taking placebo. In depression, we don't know why placebo effect is so important. Maybe you should have compared to therapy, then minimum HAM-D points decrease should be 6 points. And the third group is not included here. The third group mentioned by the previous speaker has not been included in this meta-analysis. The third group should have been taken into consideration. You know that the media is following up such studies very closely, and he is also giving his data secret. He is not giving us information about the data, and that is also a further criticism. The protocol is incorrect. Literature screening has not been fully completed. We don't know which antidepressants are included, which are not included. In literature screening, we should ask why he has not included studies on placebo effect. And we don't know why which criteria is selected and based on what. I believe that we can criticize him for his acceptance and rejection criteria. I wanted to speak about the meta-analysis. He has used a stable effect model, but if you use a randomized effect model, then the results should be different. So homogeneity test has not been performed very efficiently. We can further criticize this study for reliability. I think my time is up, therefore I will have to stop here. And finally, as a result, I would like to underline once more that even though this is a good study, the objective has not been clearly defined, and the results are misleading for the general public. We all believe in random controlled studies, and we believe that they are quite acceptable in the evidence pyramid. He should have included SSRIs. We have seen patients who have benefited from antidepressants